Hello everyone. In this video we'll be seeing about nephrotic syndrome. In the previous one we have seen about the post-streptococcal glomerulonephritis and which is the most common cause of nephritic syndrome in children. In this video we'll be seeing about nephrotic syndrome. So similar to the cardinal features which is present in the nephritic syndrome, there are also cardinal features of nephrotic syndrome. And the first most important cardinal feature, hallmark feature is proteinuria, which is significant proteinuria. When compared to nephritic syndrome, the proteinuria will be on the higher side in nephrotic syndrome. That is more than 40 mg per meter square per hour or more than or equal to 3.5 gram per day. But in nephritic syndrome, the protein loss will be less than this. This high range of proteinuria in nephrotic syndrome is called as nephrotic range proteinuria. And the second feature is hypoalbuminemia. Since there is loss of albumin through urine, amount of albumin in the blood will be reduced. So there will be hypoalbuminemia. And the third feature is urine protein and creatinine ratio will be more than 2. The reason behind this is, since protein is lost through urine, its level in the urine will be more, its amount in the urine will be more, and creatinine will be excreted less because the renal function is impaired here. In nephrotic syndrome, since the renal function is impaired, the creatinine which should be normally excreted through the urine will not be excreted through urine. So the creatinine which is on the denominator side, its value will be less. Since protein which is in the numerator side, its value is high, so the ratio will be high. And urine protein creatinine ratio is the diagnostic test. If the examiner asks you what is the one diagnostic test you will do to diagnose nephrotic syndrome, and your answer should be urine protein creatinine ratio, and the value should be more than 2 to diagnose nephrotic syndrome. And urine dipstick test will be 3+ or 4+. Urine dipstick test is a quantitative test to detect the amount of protein which is lost through urine, and it shows 3+ or 4+. And there will be hyperlipidemia, lipiduria. Also, since there is hyperlipidemia and lipiduria, nephrotic syndrome is also called as lipoid nephrosis. The reason behind hyperlipidemia is, since there is reduced protein in the blood, and this reduction in protein level in the blood will be detected by the liver. So the liver detects the less amount of protein and it tries to compensate for the loss of protein. In the name of compensation, what it does is it increases the lipoprotein synthesis. This abnormal increase in the lipoprotein synthesis will cause hyperlipidemia, and as a consequence of hyperlipidemia, lipiduria occurs. Lipiduria is a loss of lipid through urine, like proteinuria. And there will be edema. It's obvious that when there is hypoalbuminemia, there will be edema. And the mechanism behind that we'll see in a short while. So causes of nephrotic syndrome in children. There are primary and secondary causes. First we will see about secondary causes. And one of the important secondary causes of nephrotic syndrome is drugs. Certain drugs is associated with the development of nephrotic syndrome, and those drugs are NSAIDs, non-steroidal anti-inflammatory drugs, interferon alpha, lithium and gold. So these are the drugs associated with nephrotic syndrome, development of nephrotic syndrome. And the second cause is malignancy. So malignancy like Hodgkin's lymphoma, CLL can cause nephrotic syndrome. And the child with allergy can also get nephrotic syndrome. So these are the secondary causes: drugs, malignancy and allergy. And coming to the primary causes we can divide them broadly into two types. That is, one is due to MCD and another is due to SCD. MCD stands for minimal change disease, and SCD stands for significant change disease. And there are two entities in significant change disease. One is focal segmental glomerulosclerosis. I have written it as FSGS, and membranous nephropathy. I have written it as MN. And so these are the two entities coming under SCD, that is significant change disease. One is FSGS and MN. The reason behind the name of these two entities, MCD and SCD, minimal change disease and significant change disease, is, and the reason is here. Since in MCD there is only effacement of podocytes. I'll tell you in a short while what is mean by effacement. For now, just remember that in MCD there will be only effacement of podocytes, but there is no reduction in number of podocytes. But in SCD, that is significant change disease, there is reduction in number of podocytes, which is more dangerous than effacement of podocytes. So in MCD there will be no reduction in number of podocytes, so it is called as minimal change disease. Only some minimal change is occurring in the podocytes, that is effacement. But in significant change disease there is reduction of podocytes, so some significant change is occurring in the podocytes, right? So it is called as significant change disease. And from the name itself we can predict the prognosis of these two diseases. MCD has got good prognosis than SCD. Since there is a loss of number of podocytes itself, SCD has got poor prognosis. And coming to the effacement, the word effacement here refers to flattening of food process of podocytes. In this picture you can see I have drawn the podocytes. So these are the two podocytes, and the projecting structures here are food process of the podocytes, and the pink color substance behind them is the glomerular basement membrane. And these two podocytes, what are they doing is the food process of those two podocytes will interdigitate with each other, and it will form a filtration barrier. So this is first picture is a normal podocyte in which there is interdigitation is normal and the filtration barrier is present. Whereas in case of MCD, these food processes will get flattened. That is the term we have seen, the effacement occurs. So the food processes will become flattened, and the glomerular basement membrane will be exposed. So there is a large area for the protein to get escaped through urine. So in the first case there is very less space so that the protein cannot escape. But in the second case, since the glomerular basement membrane is exposed, the protein has more area to get escaped. So this is the reason behind the loss of protein through urine. And the most common cause of nephrotic syndrome in children is MCD, minimal change disease. And second most common cause is FSGS, and least common is MN, membranous nephropathy. And you need to know about some differentiating points between MCD and SCD, minimal change disease and significant change disease. The age at onset for MCD is 2 to 6 years, and for SCD is more than 10 years. Somewhat adolescent children will get affected by SCD more commonly. And gender, MCD you can remember in this way, M for M. So male child will get affected more than female child. But in this case SCD, it won't spare both female and male gender, since it is a very bad disease. It affects both male and female. And hematuria, it will be absent in MCD, but in case of SCD it is present. But we have seen that hematuria is a hallmark feature of nephritic syndrome, but SCD is a nephrotic syndrome, but it also shows some hematuria. So it is called as nephritic onset nephrotic syndrome. So in FSGS and MN, which are the entities coming under SCD, there will be mild hematuria also. So FSGS and MN is called as nephritic onset nephrotic syndrome. So when the examiner asks you what are the diseases coming under nephritic onset nephrotic syndrome, you should answer FSGS, that is focal segmental glomerulosclerosis, and membranous nephropathy, MN. And response to steroids, since MCD is a somewhat good disease compared to SCD, it shows excellent response to steroids. Most of the patient will undergo remission after taking steroids. They will show excellent response, but the response to steroids is unsatisfactory in SCD. And the prognosis, we have also already seen that MCD has got good prognosis and SCD has got bad prognosis. And before going to the treatment of nephrotic syndrome, we should see some complications of nephrotic syndrome. So first important complication is thrombosis. The patient can present with deep vein thrombosis or renal vein thrombosis. And this thrombosis is due to the loss of three important proteins: antithrombin 3, loss of antithrombin 3 in urine, and loss of protein C and protein S in urine, and loss of prothrombin in urine. So these are the proteins whose loss is responsible for the thrombosis. Thrombosis is a clotting of blood, right? So these are the anticoagulant proteins. So since the anticoagulant proteins are lost through the urine, there is increased risk of coagulation and it will lead to thrombosis, and it can present as deep vein thrombosis or renal vein thrombosis. And next important complication is spontaneous bacterial peritonitis and pneumococcal peritonitis. Spontaneous bacterial peritonitis is also referred as SBP, and the reason behind these complications is due to reduction of albumin. So when there is albumin reduction, the oncotic pressure will get reduced. When the oncotic pressure reduced, the oncotic pressure is responsible for trapping the fluid within the vessels. So when oncotic pressure reduces, the fluid cannot be retained within the vessels, and the fluid escapes out of the vessels when there is reduced oncotic pressure. So there will be extravasation of fluids. The fluids from the intravascular volume will escape to the extravascular volume. So the extravascular volume will get increased, and that will manifest as ascites. So since when there is ascites for longer time, it will get affected, it will get infected. So it may lead to spontaneous bacterial peritonitis or pneumococcal peritonitis. Of these two complications, pneumococcal peritonitis is of much significance because it is the most common cause of death in nephrotic syndrome. So we should be careful about this complication. And the intervention for pneumococcal peritonitis we will see in next video along with treatment. And here is one question for the viewers. In treatment of nephrotic syndrome, Lasix, that is furosemide, should not be given to reduce edema. So generally we know that in case of edema we should give furosemide, but in nephrotic syndrome induced edema, that is edema due to nephrotic syndrome, we should not use furosemide. And if you know why, you can mention the answer. You can answer in the comment section. I don't know how many response I will get, but if you see this video, just if you know the answer, comment below. And this is about complications of nephrotic syndrome. We have seen about the basic characteristic features and causes, primary causes, secondary causes. Secondary causes includes drugs, malignancy and allergy. Primary causes includes two major entities, MCD and SCD. MCD is due to effacement of podocytes and no reduction in number. Effacement is flattening of podocytes, which causes exposure of glomerular basement membrane and more area for protein to get filtered through. So protein loss occurs, proteinuria occurs. And in SCD there are two diseases, FSGS and MN. And we have seen the difference between MCD and SCD. MCD has got good prognosis and bad prognosis. SCD has got bad prognosis. SCD affects somewhat older children, and it equally affects both males and female, and hematuria will be present in SCD. So that is called as nephritic onset nephrotic syndrome, and it has got only unsatisfactory response to steroids, and we have seen 2 complications: thrombosis, in fact 3 complications: thrombosis, SBP, and pneumococcal peritonitis. And I'll end this video with a question to you guys. So this is the question: in treatment of nephrotic syndrome, why Lasix, that is furosemide, should not be used to reduce edema? And if you know, you can let your answer in the comment, and please do share and subscribe. Thank you.